Um, so again, I'm Dr. Ryan Morrison. I'm here in Kanawha City. We got about 100 patients or so here in my recovery programs. And the one I'm presenting on today is one of the patients that we've had since near the beginning of us starting to do this. Is a 38-year-old female that we first started in our programs in March of 2017. She's one of the few Black patients we have in our program, and she's on Medicaid. The questions I have with her have to do with the Coates model phases and moving back and forth between them. So historically, we had phase 1, 2, and 3 with the Coates model, and then there was IOP, which would be like twice a week or 3 times a week, or even every day. But she has been, for the last year or so, we've had a phase 4, which I believe is something that West Virginia University did first, and we copied, where she only comes every other month. We do a 28-day script with 1 refill with her. She's been sober like 1,800 days, some insane number of days. So question 1 was, is phase 4 still a thing, and how is it working with COVID? The question 2 is, this patient actually has just had an unreported alcohol relapse, and so I was curious, like, how many phases they would move and how this would relate with phase 4. And then they also, with the alcohol, had cannabis use as well. And I was curious just to distinguish between the two. Had it been just cannabis, well, how would it be different, or would it doesn't even matter? And then number 3 has to do with how big of a factor is the timely admission of this use with the phase escalation? Does that become a non-factor once we bring alcohol into the decision tree? And do we have to go up more phases because it's alcohol, you know, whether they admitted to it or not? And would we even, because this patient actually has a lab test that, like all patients, that's not 100% reliable, can we even say that she's being dishonest when she still denies any alcohol use? So there's a lot of sub questions that come in. So I'll go through her case and we'll see what you guys think. So again, she's been with us since March of 2017. Initially, just couldn't stop smoking cannabis, but back then we were pretty strict on cannabis, and she would have had to quit, or we would have eventually discharged people over cannabis alone back in those days. And so she managed to quit completely, even within her first few months in the program, and then basically stay sober from then until now. Throughout the many years I've known her, 4 years I've known her, she's always presented in a very, put together state. Never seemed to have any behavior that wasn't consistent with her being in recovery. Always was very supportive of other patients and very cooperative, and pretty much followed every rule for years. And we had a lot of them. And she's been working as a teacher. And then just on the April 20th visit, which was a coincidence, she did not disclose, but we could see in her prelim drug screen that she had used cannabis. Although I guess it could have been a false positive. The send-out was confirmatory for the cannabis. And it was, surprisingly, our panel that we got also found an ETG, ETS, ethyl glucuronide, ethyl sulfate, levels of 655 and 962 respectively. So I asked for her to have a random callback to recheck it. At that random callback, she admitted to the cannabis and denied the alcohol. and the send-off actually from that one was negative for alcohol. So it was only the April 20th when that was positive for alcohol. At the time, even though a long time ago we had an echo about the reliability of ethylglucuronide and ethyl sulfate, indicating that this was pretty reliable readings, that this is very, very likely alcohol use, like over 90%, maybe 99% certain that the ethyl sulfate is considered the confirmatory. I just escalated her one phase for not admitting the cannabis and held off on doing anything about the alcohol, which was unadmitted, until I could talk to Morgantown. So some other details, she's at a very remote testing for Hep B, C, and HIV that was negative. She had been on Suboxone even before 2017. And when she initially came to us back then, they had detected large amounts of fentanyl in her drug screen that she had denied using right before she switched to us. And I have to say, we have really crappy ability to detect fentanyl use with my current drug screening algorithms. I think it's only in the drug screens for a few days, and we don't generally do send-offs for comprehensive testing in these long-term patients. Like she would only come in once every 2 months under phase 4 rules, and we only do the comprehensive if we have a reason to think we need it. So it was only because that THC showed up. So we've not really been monitoring for these 4 years very aggressively for fentanyl. It would have been easy for her to slide past many fentanyl uses without us detecting it. Although even if we detected it, we would have never discharged, as what happened that led her to us. We would not discharge of her fentanyl use ever. She has a husband that is, that they have they had a child together, but he died in 2015, and that's connected in, but I think her substance use disorder started long even before that. The husband has been in and out of recovery programs the last few years, including ours, but he's in another program at this time. Behavioral assessment, it was pending on my prior case submission, and I just didn't put anything in. My behavioral assessment is that she's not depressed, but she does have like sort of a pseudo PTSD over the loss of her son in the past. So I think that's all I've got for this case. I'm ready to open her up for people that know the answers to my questions.
That's excellent. Thank you so much, Dr. Morrison. As always, you do such a wonderful job presenting cases, so we truly appreciate it. Before we have any case recommendations, or before anyone can address the questions that Dr. Morrison had, were there any clarifying questions for Dr. Morrison in the case? Feel free to unmute or chat in.
I have a question. Dr. Morrison, what is her maintenance dose? Suboxone.
16 milligrams.
Okay, it's film, right? I just want to double check. Okay, yes. So how did she react when you told her she will be sent to monthly group? I mean, basically you changed to from phase 3, phase 4 to phase 3. How did she respond?
She was excited. She was like, oh, I really prefer monthly. I do well in monthly. It was this whole being bi-monthly that made me slip up with the cannabis, but I did not drink alcohol. But I really just want to stay monthly from now on. Is how she handled it.
Okay, I just want to clarify, because this level, we're talking about 655 over 692, both ETG and ETS. I think I consulted our lab people before in the past. I think this is pretty confirmatory for alcohol use. Maybe she didn't use a lot, but this is probably over 99% true she was using. Yeah.
Ryan, how's her functioning in life? I mean, sounds like she's doing well, right?
Right.
Is that, yeah, okay. because I think that that's really important. Is she dysfunctional or functional? And, I think what Dr. Zhang said, about having her coming in more frequently and she's open to that, that's a good sign. I think a lot of patients have that same need.
One thing I love is when WVU tells me I should be more strict, and then I can blame it on you guys when I tell the patient that I have to escalate her care further.
I love that, Dr. Morrison.
Yeah.
Dr. Hirschler, was there something you wanted to add as well?
Yeah, what I was going to say is that, the concern to me is that she didn't bring up the fact that she was using marijuana and it had to be discovered. So it makes you wonder how long this has been going on for. And, that whole mentality in the group of not kind of being open about her use, that's interfering with her treatment. And so whatever level of care she goes to, she needs some random screens to kind of rein in this behavior so that you can, she'll need more consequences if it continues and she's dishonest about it, or maybe she can just work on recovery and talk about what's really happening.
Thank you, Dr. Hirschler. Were there any other comments or feedback, recommendations?
The only thing I can really think of too is, I don't know what the staffing is like down there, but if she is not established with an individual therapist, I think that could be helpful to maybe address some of the underlying, as you called it, pseudo PTSD from the death of her son. I don't know if, we know very little about it, but we do know a lot that with PTSD, folks will oftentimes use things like marijuana to calm down a lot of those intrusive symptoms. So that might be an option for her, even though it's not a requirement according to the code model.
Yeah. And Ryan, also, you said she was a teacher.
Mm-hmm.
Is that correct? It's been a tough year for teachers. I think, if you think about the level of stress they've had this year, I would think. And so I agree, kind of some more intensive therapy. We just had somebody that went from bi-monthly to weekly because she needed it that much. So I think it's okay to step people down if that's what they need at the moment. I said, you need to come in weekly for a few months, and she was okay with that. She actually was grateful. So.
And part of doing what Dr. Baltier was talking about is it's kind of, it's turning the power back over to the patient. So it's saying, hey, we're recognizing your struggle. Here's what we can do as a clinic to help. So they then have the choice voluntarily at first before it becomes an involuntary requirement from the clinic.
Dr. Houston, I saw you unmute a few times.
Only once, but yeah, I think you did the right thing, Ryan, with it monthly. If she's still struggling or if she wants to do more often, I think that's fine. The idea of why didn't she disclose it to begin with, because she's known you for so long. The PTSD stuff, I would venture if you went down that rabbit hole, she's been struggling. I can't imagine being a teacher and having lost your own kid too. Kind of reminded every day of that kind of stuff. So, it might be as simple as having a good therapist and maybe getting on an SSRI and giving her a little extra support, but I think you're doing the right thing.
To answer your question, number one, is code still using phase 4 bi-monthly? Actually, yes. We are still doing this virtually to many patients, bi-monthly groups. Actually, we have currently we have about 550 patients, active patients in our code, and we have about 80 to 90 patients, between 80 to 100 for sure, patients in bi-monthly groups. So we have a quite good percentage of people who are over 3 years. Actually, one of my patients had a 7 year of sobriety, then started struggling because of all different kinds of things in the family and job. So she was not honest. She missed a urine drug screen. So I changed her to a bi-weekly group, basically changed from bi-monthly to bi-weekly, and it has been working well. And she's very appreciative, and she has been much better now. During COVID time, and for the virtual bi-monthly group, we see, because I have two very large bi-monthly groups, so we have like I have to see like a 16 to 18 patients each time. So I talk to them very briefly and let them go. And Dr. Barry and Mashalik, they're all doing the same thing. So for this group, so I guess COVID probably did not really change the way we see them. However, we have been calling them back for UDS and pill counting, same as before.
I had one other thought about this case. You know, the husband who is in and out of treatment may be making a kind of an unhealthy recovery environment for her at home. And so maybe if she does get a therapist, having a family session to send out feelers about what the home environment is like and how healthy that is and what to do to intervene.
All right. Where he used to be our patient, we crossed that bridge a long time ago, and it's very sensitive to talk about her husband with her. He's got. I don't think she'll leave him no matter what ever, but I do think that he is a part of the challenges that she faces trying to stay sober. I don't think his recovery is as strong as hers is.
Is she involved in any support groups like Al-Anon?
No. She used to, when we first started in the program, we 4 12-step meetings a week for everybody. So she did her 12 steps. She worked all her steps and worked them all. I had a sponsor and everything for years. But since COVID, really even before COVID, where we don't require 12 steps after 1 year with the Coates model, we've seen very few. Actually, we only had one person who made it to 1 year. We had like 50 people to 1 year sober. Only one of them kept doing the 12 steps after they were no longer required.
My suggestion would be that if she doesn't want to continue with 12 steps for her, she can look into Al-Anon. They also have MARA meetings, Medication Assisted Recovery Anonymous. I don't know if you guys have them, but we have them here in Houston and they're virtual, so anyone can join. If she technically doesn't have a year anymore, I mean, she has a year in your program, but people tend to step away from the program after 1,800 days. And I can imagine she decided she didn't need it anymore, and COVID's caught a lot of people off guard, so.
Yeah, I also want to plug Mara. We do have it here. I'm very excited about it. Thanks to one of our recovery coaches and care managers brought it here. And we're very excited about it, but we've not been able to get participation very well yet. I think we're looking at maybe re-requiring meetings again. I was hoping to get some WVU support for that as well. I didn't think about that as a question.
I kind of agree very much with Phil. I think we should take this opportunity to explore the reasons of her use and provide individual counseling. I think that's going to be, especially even for a few like acute sessions, could be very helpful, because I don't know about her attitude or her general view about using marijuana or just drinking alcohol probably once a while, just a couple of beers, occasionally. She might have different kind of, opinion about different, we're talking about insight. Also, we don't know the way she coped with her stress. So it's a good time to learn about it. I think a lot of times in my bi-monthly group, a lot of people, you can feel like if they continue to do meetings, if they continue to facilitate meetings, chair meetings, they definitely do better. However, a lot of people, they have normal lives like you and me, and they probably don't they probably don't even care about meetings anymore. So sometimes they do struggle. So personally, I think that smoking marijuana and drinking alcohol, probably not very much, but could be her, bad way of coping. And she probably didn't think it's a big deal, but unfortunately, it's a good time for us to to learn about it and provide education.
Yeah. So
Not to punish her.
Dr. Z, there's a question with that, because I think what you're getting at is a use disorder at that point, or is she just not abiding by the rules of the group? If, let's say she's, because I think that's what you're getting at, why is she using? Is it, to cope? Is she coping inappropriately? And maybe it's the other stuff. But let's say she says, nope, I just use it to relax every once in a while, and it doesn't interfere with anything and all that. And again, not saying that it's a full pass, but it's a little different than somebody who says, I'm out of control out of it. I feel like I'm not addressing my emotions, those kind of things. And I think it is kind of trying to figure out what she's going through, correct? Yeah. And then I have a question for the people in West Virginia in terms of Medicaid, because Medicaid only does phase 1 and phase 2, correct? That's my understanding, that there is no phase 3 in Medicaid, and they have to continue to do monthly therapy sessions. Is that right? Okay. Yeah. So in Morgantown, do you guys still require them to do monthly if they're on bi-monthly medical? No. Okay. Okay. Because I've run up against that. OFLEX says one thing and Medicaid says a different thing, and they're not the same. So.
Thank you for those questions, Dr. Baltiera. Were there any other questions you wanted to address about the case, Dr. Morrison? I know you had a few there. I'm more than happy to pull the case back up as well.
The question 2 and 3, actually, Dr. Morrison, I want to, I want to put a quick comment here, like how does honesty, timely admissions of use currently factor into decisions? Because before, I really had trouble with one of our, ways to deal with this kind of dishonesty. Because I give you an example, when we were back to the in-person time, face-to-face groups. So a patient, we asked them to basically to fill the form. The form, by the time they fill the form, they have to put exact sobriety time or sober time. So they put like 12 days or 14 days. Then they, by the time they get a urine drugs, of course, they didn't know they may, whether they will get a urine drugs or not. Sometimes they know. Then they still lie. They were not all honest. But during the group, and even sometimes before the urine drug screen, and because we call them randomly, so call them out for urine drugs in that time. So sometimes even before they know they will be screened, they become honest, because I can see they're fighting in all the time internally, trying to figure out whether I should be honest or not. But in the group setting, sometimes they become honest. So, but we still consider that as a dishonesty. So we're pretty rigid. I'm talking about, very strict. Well, you did not put, when you fill the form, that's the time you have to be honest. We do actually tell patients many times, we repeat that. We emphasize you have to be honest at the time you fill the form. But I still think, we're human beings, and when we are struggling with drugs, alcohol, then probably lying is just is a part of it. So we're learning how to be honest. So I don't know whether we should be very rigid. Or like, how soon you should be honest, and you should tell us about you. I guess the goal, our treatment goal is to get their lives back. So I still don't know. I mean, it's a very good question for group discussion here. Then how strict should we be with all these kind of rules, and especially we're talking about how timely should we be with this honest answers.
One of the trauma therapists that I read a lot of their material has a quote, "It's what you've done to get you here that makes you very brave." And a lot of times when I think about these single isolated slips, I don't even feel comfortable always calling them relapses. It's what they do after the event that I think we need to hold them to the standard. So do they come to us and are they honest about it? Like, hey, I had a really crappy week last week and I smoked some pot to calm down. So part of me feels like we should celebrate their honesty, that they are making those life-changing statements, right, that Dr. Zhang's talking about. And, we should praise them for how hard that was. And if they come in and we give them a urine drug screen and we say, hey, you're honest for THC, and they deny it, we then talk about how difficult it is to come in and be honest, and what can we do to ease some of that anxiety about being honest with us.
Yeah, and I think it would be really neat to see, because we all have all these programs and have different rules, but what really are the core elements for people to change and get their lives together and stay that way? Is it the 12-step? Is it the Suboxone? Is it the honesty? Is it the drug screen? Is it all together? My feeling is it's not all of it. There are elements that I think are more critical, and then there are elements of total programs that are critical, but I'm not sure every element is critical in every program. And so that's how you tease out the evidence. And it'd be really interesting to put, comparison of programs, plus or minus 12-step, plus or minus, we call them lapses. I think, that's kind of, because I agree with you, it's not a relapse. They've had a lapse. Their life isn't what it was. And so really trying to pare down to what the evidence is and what's critical to it. And I suspect it's not going to be one thing, but it's not going to be all things either.
I would like to make one comment as a 12-stepper myself. The fact that she's still in that unhealthy relationship tells me, it causes a lot of concern, because I know as a 12-step person, I couldn't be in a relationship with somebody that continues to use.
I didn't bring it up earlier, but even though he's in another treatment program, her husband, she has told me that he is like a daily cannabis smoker. So that's, I think, explains the cannabis, at least, what's constantly triggering her on that.
I see a lot of heads nodding.
I was curious about the cannabis, Dr. Morrison. I just messaged you privately, but I'll just go ahead and ask. I'm not sure if I heard you right. Did you say that I was curious about her sobriety from cannabis, that she was able to quit it pretty early on. And did you say that you dismiss for people who have persistent cannabis use?
Yes, we did. We did. I started this thing even before Dr. Berry was here with Dr. Sullivan, and the rules back in 2016 with even the Coates model were, if you couldn't eventually get it under control, I mean, you were given time, but you would eventually be discharged for even cannabis use.
And so I'm curious for more details. How much time? And there's, coming in weekly with cannabis, but then there's coming in, occasionally like this. So it feels thorny to me.
I guess the premise I like to use is that if someone is failing the current level of care, what I want to do is to intensify the treatment, not discharge them from the program. And so if they're failing the current level of care, they really need more care or better care or a combination of both. And
that's when we have a lot of our patients leave, unfortunately.
I guess the hardest part for Dr. Morrison is, you're in a remote area, you're talking about rural area, underserved area, so not many available providers, right? That's one thing. Second is unfortunately, you're taking care of a group of people, you have to use the same standard for everybody. So if somebody really, keeps smoking marijuana, but your policy is no, I just cannot let you do this. I don't feel comfortable continuing your addiction care because of whatever your rule is. I think it's very reasonable. So for us, we have here our advantage is we have different clinics. Usually I remove them from the group setting, but I try my best to keep them in fellows clinic or different kind of individual clinics, and still try to do harm reduction, to my ability. It really depends, case by case. But I think I guess like I said, the advantage is we do have different kind of settings, and we probably can treat some patients very differently occasionally because of different reasons.
And Jen, I noticed you had unmuted a little earlier. Was there a comment you wanted to add?
That might have been an accident. Thanks.
I think I'm too good at spotting people on mute, so I do apologize if I ever do that to you all. Any other comments or thoughts? Dr. Morrison, was that everything about the case that you wanted addressed, or was there anything else you wanted to discuss with the group?
No, I really appreciate all of the great feedback that you all helped me with. I think you guys really covered it well.
Awesome. Well, thanks again for the awesome case presentation. We appreciate it. All right, Phil, I'll turn things over to you. If you have any trouble sharing your screen, I have it on my end as well, but I'll turn things to you now. Thank you.
Okay. It's been a minute since I've done this, so here's hoping I don't mess it up. It's good practice for tomorrow, but you guys can probably see my note slide, can't you?
On my end, I actually don't see the notes. Does anyone else?
Really?
Nope.
That's such a fun trick. I need to know how I actually did that for tomorrow. This is going to tie a lot in with what we've already talked about with Dr. Morrison's case about just building patient trust. So it's really good timing. Dr. Morrison and Mitra, thank you for setting this up so nicely. So what is provider-patient relationship and with building trust? So doctor-patient relationship lies at the heart of healthcare, and patient trust is a fundamental aspect of that relationship. We all see that every day in what we do. If a patient trusts us, they can be honest with us without judgment. And man, that's really important in what we see in COAT and what we see with Dr. Morrison's case, right? If patients aren't being honest, what can we do to get them to feel a little bit more comfortable so they can provide that information so we can best help them? We're not mind readers. I joke with some folks, I skipped that class in grad school about reading minds. So I can't help them unless they're open and honest with us, especially right now in times of COVID where a lot of our folks are still through tele. So I feel like we miss a lot of the body language in having these discussions. So just some 3 ways to build patient trust. So we want to communicate often and well. And it sounds like Dr. Morrison and all the other clinics that are always so open and sharing about cases as we do this. So we communicate often and well so we can help establish trust with our patients. Obviously, we have to build that relationship, so we go through this kind of getting to know you phase, so we can establish a snapshot of their life, learning hobbies, friends, family, their day-to-day activities, working environment. But then it's taking that and it's expanding it too, so it's not just talking about these surface level things, it's also building part, how do you cope with these stressors? What kind of triggers those responses? Being a good communicator, in the helping professions, educating patients on various health challenges they're facing. So, I believe a lot of it too is normalizing their responses. So folks who have spent a lot of time using marijuana to cope with stress, there's going to be that adjustment period, and we want to normalize that experience, but we also want to help them learn new strategies along the way. So one thing that I kind of do is I say, so yeah, you've used marijuana this time, but what's one thing you can try next time before buying or obtaining the substance? And we try and find that new strategy that's going to work for them. And we also always want to be a good listener. That's a huge part of communication. And that's where kind of some motivational interviewing techniques will come in that we'll talk about later. We want to be able to express some empathy without being emotionally overwhelming ourselves. Which can be a trick sometimes if we feel like there's been a lot of relapses in group, how do we not internalize that on ourselves? We may have a lot on our mind. The patient may not be the most pleasant person to be around, perhaps due to stress, pain, confusion, other issues. But it's important that we are mentally present with the patients in groups or individual settings. And we want to try and relate while still having some walls between us and what the patient is going through. May help us make objective decisions while advocating for the patient. We may want to come across as calm, competent, and in control of the situation. Our confidence helps to reassure the patient that all is as it should be. If a situation occurs that is frightening for the patient, they can remain calm and assured that we have it handled on their behalf. A lot of times when we have those conversations with folks that, you know, they're going to go from bi-monthly down to monthly or bi-weekly, those conversations are not smooth sailing. And we want to kind of project that calmness, even though they might be projecting frustrations and irritability. Just looking at some ways to increase retention by building trust. Asking patients questions to improve their experience. I like checking in with my co-patients every so often, you know, what's going well for them. And it's about, you know, kind of growing my own clinical practice, but it's also about, you know, seeing if there's any needs that I can advocate for them on behalf of the department. Answer concerns directly. So, you know, for those of you, spoiler alert, if you're sitting in on my presentation for the Addictions Training Institute tomorrow, don't chime in with this part. But when talking with veterans, the key is to be direct. So I tend to take that to the COATS model too. To be direct, I tend to not beat around the bush. If somebody's being dismissed or sent to a higher level of care, you know, this is why our case managers are excellent at doing that as well, while also being empathetic. Compassion is huge, and we'll talk about that in a little bit. We want to offer additional useful information. So as, you know, MAT is growing in our communities, as recovery components are starting to come back to in-person, you know, letting our patients know that. A lot of them do not really click with Zoom doing self-help meetings. And so as meetings come back to in-person, we want to let them know that. Communicate effectively by listening actively. So using all of those meta communication techniques that, again, we lose out on Zoom whenever we only have 5 windows to stare at while doing presentations and chatting. And then we want to build trusted long-term relationships with our patients. And I know that for me, working at a small satellite clinic, alongside Dr. Herschler, that was always a really great treat to be able to watch patients graduate, you know, from weekly clinic all the way up to monthly clinic, and then seeing them be able to leave monthly clinic to go to bi-monthly. It's just always a great treat to watch them and to celebrate those accomplishments with them. Some communication strategies. So, you know, using language judiciously, so we wouldn't address any kind of language barriers. It's not just whether somebody is primarily Spanish speaking, you know, it's also cultural based too. So, you know, asking questions for clarity, you know, even going all the way up to getting interpreters if needed, right? I'm going to create a non-judgment environment. I jokingly call my office the Planet Fitness of therapy. Okay, I got 1 laugh, that's good. So if you don't get it, Planet Fitness is a judgment-free zone. You're thrown out if you grunt too much or anything like that. Hopefully all therapists and anybody's offices are judgment-free zones, but I jokingly want to paint my walls purple and write it on the wall. But creating non-judgmental environments, we can use motivational interviewing, we can use open-ended questions. A lot of times if we're asking closed-ended questions, I feel like folks can feel like we're interrogating them as opposed to creating a therapeutic and supportive environment. And then we want to level with the patient too. So honesty is key. If we're asking them to be honest with us, we want to give that to them as well. We want to be open and honest with them about our thought process, our reasoning, as to why we make the decisions clinically that we do as a treatment team. A lot of us have probably learned about motivational interviewing throughout our careers, but I stand by it's never a bad thing to review a little bit. So it's a counseling approach designed to help individuals resolve ambivalence about their alcohol or drug use and support efforts to change. MI is often delivered as brief intervention based on client-centered principles. One of the core stances of MI as clinician is that they do not argue in favor of change or attempt to convince patients that change is in the client's best interest. Instead, they elicit the patient's own arguments for change. So, you know, we try to promote positive collaborative relationship. We want to promote engagement, reduce resistance, assisting patients who are experiencing paranoia or psychotic symptoms. That happens from time to time. Dr. Zhang, I always appreciate your head nods. And then we want to help patients recognize negative consequences associated with use. So for me, we talked a lot about marijuana. When I'm seeing folks individually who talk about smoking, I always let them know, hey, it's still illegal in the state of West Virginia. So you have to be willing to face the consequences of your use, should you get caught. And please don't come to your sessions high. That's kind of rule number one for me. Looking some more at MI skills. So reflective listening, affirmations, again, open-ended questions. We want to do a lot of summarizing, elicit change talk, and then we also want to avoid confrontation. Advice is typically only given on request and with patient permission. And a lot of times MI, just like with other therapeutic interventions, it's combined with things like cognitive behavioral therapy. And that's to enhance treatment retention and engagement. So if we're sitting there telling folks, oh, tell me more about that. Tell me more about that. This is no stab at the online videos of how to do therapy, but sometimes that's what those online how to do therapy videos sound like. Can you tell me more? Oh, expand on that. So continue to grow. Compassionate consequences, it's our language that we use is always so important. So we have the potential to be so more effective with our patients if we talk to them with compassion and empathy. So early on in addiction treatment, confrontation used to be the go-to model for therapy. There are times though where we still need to confront patients on the reality of the situation, but confronting a patient with force and aggression is simply a way to shame them into honesty. Instead, holding them accountable with respect is a way to communicate, I care about you enough to be honest with you. So we use compassionate approach, right? So addiction's a disease of the brain. Oftentimes, like what our case was about, the link between trauma and substance use disorders. If we don't address the underlying issue, oftentimes I'm a firm believer we're just putting a Band-Aid on the situation. Once everything gets re-triggered, the trauma gets re-triggered, then we have to worry then about an increase in relapse. So guilt and shame as relapse triggers. Again, compassion is truly effective. And then holding patients accountable. Every action will have a consequence. Expectations are clear and communicated at intake. But as we are finding up here anyway through observation is that, it's important for us to review those expectations. Our patients are not always in the best state of mind at their intakes. And so reviewing that, it's stressful, right? We're coming in, we're asking a lot of their history questions, not just about their substance use. They might not be retaining all the information we're telling them in our code agreement. So reviewing that can be really helpful. And then finally, looking at our language. There's a huge change in how the words that we use, all the way down to what they hear in meetings. Hello, my name is John and I'm an addict. Should we really be saying, hello, my name is John and I'm a person in recovery? Doing a lot of groups with Dr. Hirschler, I always appreciate it when he talks, not to throw him out here, but I always appreciate when he talks about positive versus a negative urine drug screen as opposed to clean and dirty, because they're not a dirty person if they've relapsed. And so that change talk is critical to recovery. Any questions? I have to figure out how to stop sharing now. Sorry.
I was going to say maybe the most basic thing. The most basic thing I've heard people say is that basically they just want to trust the clinician with their life. And so if they can put their life in your hands, that's where you want to be with the patient. And so that comes from caring about the patient. I agree with all the things that you pointed out, but I think that's the key to it, really.
Thanks. That was a great presentation, and I find that the hardest aspect for me in establishing trust with patients since I started, and I've only been doing this a year and a couple months, is getting to establish trust in a group setting. I never see them individually, and I see them for their medical visit. And so it's tricky. I wonder if anybody has any tips on that. Another disadvantage I have is that I work in concert with my partner, Angela Barker, and right now she does the inductions, and so I'm not even getting, and other providers do the medical visits, so I'm not even getting to see them one-on-one at any point. I'm just kind of falling in cold into the group, and it's awkward at times.
I think a lot of it is just continued active listening, truly hearing what the patients are saying to us. I don't want to speak for the doctors, and I trust, but from what I've seen in working with a lot of the physicians at Chestnut Ridge is it's the active listening component. Do we hear what the patients are telling us, or do we cut them off and stick, to just certain aspects? But it's important for doctors, when I go see my primary care doctor, I don't want them just asking me questions that have absolutely nothing to do with what I'm talking to them about. So what we need, and we kind of provide that to the patients, and sometimes it's asking for clarity too.
Did anyone have any other comments, questions, or thoughts that they wanted to share with the group?
I know when they're talking about words and stigma that they're even getting away from MAT and calling it different things like pharmacological therapy, and instead of using positive and negative, they're using expected and unexpected terms. So even some of that's changing as well.
That's really interesting. Thank you for sharing that. Dr. Houston?
Yeah, I was just gonna say, the MAT, I think the only reason they've changed that really is because of the connotation over the years has been negative. The big one they say now is medications for opioid use disorder, MOUD. You hear that one. I don't think there's anything inherently wrong with MAT, and really I look at MAT as, everything is MAT that we do. So MAT for depression, MAT for alcohol use, MAT for opioid use. So I think if you look at it very narrowly, maybe it's a problem, but at the end of the day, we're just trying to help people. And I like MI definitely. What I try not to do with my people is follow like an exact script, like how many days, sober, not sober, blah, blah, blah. I could train a robot to do that. So really the empathetic kind of touch and having people realize that you care, because one of the best sayings I ever heard from a physician as an oncologist when I was in medical school, it's a little corny, but he says, people don't care how much you know until they know how much you care. And I truly believe that. So you can be the most brilliant person in the world. If you have zero empathy, zero true compassion for people, no one cares what you do. So you have to show that you're empathetic and caring. Otherwise, what's the point of all this? So there you go.
Thank you for sharing that, Dr. Houston. That's a great quote. I agree totally. Any other thoughts or comments?
I'd just like to do a shout out for the model as a team-based approach, and to my team in particular, who none of them are on here, so they don't know I'm saying this, but it's really critical for me in that compassion and consequences part of the work, that we are a team and that there is conversation and planning. It's really, frankly, superior to the other chronic disease care that I do, and really inspiring to be a part of that team. And I think it makes the approach I think that builds trust with the patient, that there's a team aspect to it, and that we as a team, we both support each other and we challenge each other in what's going on with any particular patient when we formulate the plan. It's just been really helpful to me. My cat agrees.
that Manny? We love him. Thank you so much, Jen, for adding that as well. It's I can only imagine how crucial that is to have that team-based approach. Any other comments or thoughts? My laptop is telling me it's 4:58 and my phone's telling me it's 4:55. So I don't want to cut the session short or anything, but anyone else with thoughts, comments, you can chat in as well.
I was just going to ask Kristen if we know what we're doing or not.
Yes, I greatly appreciate getting to listen in. My mother actually is from Charleston, so and I do a lot of family history work, so getting to see places like Cammon Creek, and I know I'm saying this wrong, but Kanawha, in, real life, I appreciate coming here. Thank you.
Kanawha?
Kana? Okay, yeah. I've only seen it written. I haven't been there, but yeah.
There's also a town called Hurricane, not Hurricane.
I've heard about that. Yeah, I'm actually a volunteer for the Red Cross, and they're sending a bunch of emails about what's happening in the Gulf right now, and I'm like, no, I'm not even over last year.
Well, we're super happy you could join us, Kristen. Hopefully you can join future sessions as well. Alrighty, everyone. Thank you so much, Phil. You have some really great humor too. I was laughing at the Planet Fitness comment, and I know you saw me laughing too. But alrighty, thank you for a wonderful session, everyone. Dr. Morrison for that case, Phil for the didactic. We really appreciate you all so much. The only announcement I have is that our next session will be on June 28th, and Dr. James Mahoney and Jennifer Martin will be guest speaking for us on neuromodulation studies for the treatment of OUD. So keep an eye out for that reminder, and we'll see you all next time. Thanks, guys.
Thanks, everyone.
Bye.
Thank you.